Bismillahirrahmanirrahim. In the second part of the topic of medications used by the dental patient, we are going to discuss remaining important aspects, starting by the topic of pharmacokinetics, which is an important aspect. And it's usually defined as the absorption, distribution, metabolism, and elimination of the drugs, which means that simply it is how the body handles these medications or these materials. And this is an important aspect in young patients and also in older adults, particularly in older adults, because they are at an increased risk of experiencing respiratory depressive effects of some medications, such as benzodiazepines and opioids. Some of these are used by dental practitioners. These patients also may be less able to compensate quickly for medications that alter cardiovascular function, such as epinephrine. As you know, this is used in local anesthetic agents and also in gingival retraction cords. And also, these patients may have an atypical adverse drug response, such as altered mental status. Therefore, the dosage of drugs commonly used in dentistry should be reduced by 50% or to the lowest therapeutic dose for individuals who are under 45 kilograms and patients who are over 85 years of age. Therefore, for example, if you want to prescribe, usually you prescribe amoxicillin 500 milligram for your patients. In the older adults, you have to modify this dose to, let's say, 250 milligrams per dose. Another important aspect is the current medical conditions and medications used by patients as they impact dental prescribing. Therefore, we have to consider what medications the patient is consuming when we do the dental prescribing. And in this part, we will talk about the drug classes that are commonly used in general dentistry. So dentists usually prescribe analgesics such as NSAIDs, such as paracetamol or acetaminophen. They also prescribe antimicrobials in the form of antibiotics, antifungals, and antivirals. They also use anesthetics commonly, either local anesthetics, local anesthetic injections, or they may do their dental procedures under GA. They also use vasoconstrictors in the form of epinephrine, for example, which is added to the local anesthetic agent or is added to the gingival retraction cords. And they also use sedatives or prescribe sedatives for patients as an important part of the anxiety reduction protocol. Therefore, these are the examples of the different most commonly prescribed medications in dentistry. The local anesthetics are probably the most commonly used drugs by dentists. We have also antibiotics such as amoxicillin, azithromycin, metronidazole, and of course the analgesics, including the NSAIDs and the acetaminophen. This is more details about the medications that are commonly prescribed by dentists in the form of antimicrobials, antibiotics, and antifungals such as amoxicillin, azithromycin, cephalexin, chlorhexidine, clarithromycin, clindamycin, and also some antifungals, and also some other antibiotics such as metronidazole, penicillin, and tetracycline. They prescribe certain emergency medications, and also they use they use local anesthetics, they use analgesics, and they use also sedatives such as diazepam and midazolam. So, taking this into consideration, we will also consider what are the drug interactions for the drugs that are prescribed by dentists. Now, it's important to highlight these categories of medications which are used or prescribed by dentists: the adrenaline containing local anesthetics, the non-steroidal anti-inflammatory drugs, metronidazole, azole antifungals, and penicillins. These are probably the drugs that mainly are concerned with the drug interactions. So let's start by talking about the adrenaline containing local anesthetics. These may interact with beta blockers, with tricyclic antidepressants, and with general anesthetic agents. Therefore, the risk of interaction is mainly in the form of hypertension or increased sympathomimetic response in case of tricyclic antidepressants, and also potentiating the hypertensive drugs leading to hypotension. Now, therefore, for example, in the case of patients who take beta blockers or tricyclic antidepressants, limit the dosage to 3 to 4 cartridges or use adrenaline-free local anesthetics. And in the case of exposing the patient to general anesthetic agents, then the anesthetist will or should carefully manage this case. Another type of interaction takes place between non-steroidal anti-inflammatories and anticoagulants, such as warfarin. There is an increased risk of bleeding. They also interact with ACE inhibitors, beta blockers, and diuretics. This will decrease the hypotensive effect or the antihypertensive effect. And for selective 5-hydroxytryptamine reuptake inhibitors, these also will interact with NSAIDs, leading to increased risk of bleeding. Therefore, we have to carefully use NSAIDs or consult the dentist. And in case of the concomitant use of NSAIDs and aspirin, we should avoid the use of aspirin or consult the doctor. NSAIDs also interact with methotrexate, leading to increased methotrexate toxicity. Therefore, we have to consult the doctor if the prescription of NSAIDs is necessary. Now we come to metronidazole. This antibiotic is used for the treatment of many anaerobic infections, like, for example, pericoronitis and necrotizing ulcerative gingivitis, periodontitis. Therefore, the use of this antibiotic should be reconsidered if the patient is taking warfarin, because it potentiates the effect of warfarin, leading to increased risk of bleeding. Therefore, metronidazole has to be avoided, and it should be replaced by another antibiotic. Metronidazole also interacts with NSAIDs, leading to increased risk of bleeding, and it interacts with phenytoin, leading to potentiating the effect of phenytoin. Therefore, patient should be monitored closely for another antibiotic is prescribed. Another category of drugs that are prescribed in the dental setting is azole antifungals, such as fluconazole and miconazole. These may interact with warfarin, leading to increased risk of bleeding. Therefore, we should avoid azoles and prescribe another antifungal, such as nystatin. Azole antifungals also interact with simvastatin, which is used for patients with hyperlipidemia, and some cases were reported, and these were associated with myopathy. Therefore, these should be avoided, and an alternative antifungal should be prescribed. Now we come to penicillins. Penicillins interact with the oral contraceptives. They interact with warfarin and with methotrexate. In the case of oral contraceptive, will lose its efficacy, leading to decreased contraceptive effect. Therefore, the patient is advised to use barrier contraceptives if penicillins are necessary in this case. They also potentiate the effect of warfarin, leading to increased risk of bleeding. And in the case of methotrexate, it interacts with this drug, leading to increased risk of methotrexate toxicity. The risk is with high dose penicillins. Therefore, we should give lower dosage and monitor these patients closely. Now, it's important to elaborate a little bit more about some special cases, such as warfarin, because of the risky treatment outcomes of this anticoagulant and the possible drug interactions. Of course, it's a widely used anticoagulant, and it's used for the prevention and treatment of thromboembolic events in patients with atrial fibrillation, in patients with prosthetic heart valves, and patients with venous thromboembolisms. This drug acts by inhibiting vitamin K dependent activation of clotting factors 2, 7, 9, and 10. The problem here is that the antibiotics prescribed by dentists may interact with this anticoagulant, and this interaction actually is a result of the fact that antimicrobial agents disrupt gastrointestinal flora that synthesize vitamin K. Therefore, this will lead to further reduction in vitamin K. And also, they decrease vitamin K absorption due to antibiotic-induced malabsorption, and they will increase the sensitivity of hepatic receptors to warfarin. Also, antimicrobials inhibit cytochrome P450 enzymes, which are responsible for the metabolism of warfarin. So the interaction of all of these factors together will lead to potentiating the anticoagulant effect of warfarin. The different types of studies and the different case reports found that antibiotics that are likely to increase INR when prescribed with warfarin include azithromycin, ciprofloxacin, clarithromycin, fluconazole, and other azole antifungals, and levofloxacin. Of course, these drugs, some of them are prescribed commonly in dental practice. Therefore, the recommendation here is to recheck INR after 5 days of prescribing these antibiotics. Now, in the case of metronidazole and trimethoprim sulfamethoxazole antibiotics, we should consider preemptive warfarin dose reduction prior to prescribing these antibiotics because of the anticipated effect of increasing the anticoagulation. So what type of antibiotics we can use for patients who take warfarin? Penicillin G, clindamycin, first and fourth generation cephalosporins seem to be the safest antibiotics to be used in these patients. However, in all cases, we should monitor INR 3 days postoperatively just to make sure that the patient does not get a serious stage of anticoagulation. Now, these are some references that you can use for to help you in drug prescribing within the dental settings. They are very useful, and you can refer to them for further information about dental prescribing. Thank you.